My name is Ulla Madsen, and I will chair this session. And I will start by welcoming Soee Jensen, who will have the first speech today, and she will talk about lower extremity amputation, my favorite topic, patient characteristics, nutritional and inflammatory status, and perspectives of nutritional care. Welcome, Pia.
Thank you. Well, first of all, thank you for the opportunity to come here to this conference and present this work that I did during my PhD. As Ulla said, the title for this talk is focusing on the patient's characteristics. We have heard a lot about the patients with lower limb amputation this morning. And then I will focus on their nutritional and their inflammatory status. And in the end, their perspective on, I need this one, on nutritional care. So just to make sure that we all know what we're talking about, here we have minor amputation and the major amputation. These are the surgical procedures. And the patient I have examined is primarily the major amputation. The indication for amputation, as we have heard already, is primarily the chronic diseases. If you look to the literature, it is diabetes and it's atherosclerosis. A minor part of the patient is due to trauma, but I will not go into the patient with trauma. And why is that? Well, atherosclerosis is what we call the large vessel disease. So they attack the larger vessels in the extremities. And then for the patient who have diabetes also, they are also attacked by what we call the small vessel disease that leads to a foot ulcer. So patient, and here we have to remember, patient with diabetes do always have atherosclerosis, but patients with atherosclerosis do not get necessary diabetes. So the reason why these patients are amputated is due to ischemia and reduced healing capacity and gangrene. So the patient characteristic, when I started my thesis in the beginning of 2012, I needed a paper that could describe the patient we have in Denmark, the patient with lower limb amputation, and there were none because we do not have a national database where we register all these patients. So the first task was to make a national register study in Denmark. And what we did was we started out taking 2 years, 2010 and 2011, and that's even almost 9 years ago. And we identified all the patients who had been amputated in Denmark. We excluded the patient who had been revised and so on, if it wasn't not on the same level. And then we took data from all the registry we have. We have 5, and I used 5 national registers. And we collected data as far back as we could, and that was 17 years, and then 1 year ahead. So what we did, I'm just going to come with the results then. We identified 2,883 patients in Denmark who had been amputated on this first level in Denmark. And what we could see is that the majority of the patients are men. It's about 60% of them are men, and they have an average age of 69, and the majority are married. And they also have the majority of them are also suffering from diabetes. The women are above 10 years older, and the majority are living alone, and they are widows. We also found that I come from Copenhagen, so I thought most of the patients were in the big cities, but they're not. 65% are living outside the larger cities in Denmark. And we also looked at their education level, and 88% of these patients, also the vast majority of the patients, have just what we call a public school education. So Then we looked at the chronic disease. They have, in Denmark, average of 6 different chronic diseases. And the first diseases are atherosclerosis, then comes hypertension, and then comes diabetes, and then heart ischemia, heart disease. And they also get 5 different types of medication. And one thing we found when we looked at the diagnosis and the medication, for example, for atherosclerosis, we found that cholesterol-lowering drugs, there was a difference between the patient who were diagnosed with atherosclerosis and the number of patients who had received lower cholesterol drugs, about 25% point. So many of the patients do not receive the medication for atherosclerosis. We also have a high mortality. We talked about this earlier, and it's about, I think, the 30-day mortality here in Denmark at this time was 19%, and 1 year is 43%. And looking at how many amputations are we performing, how are the difference here? The majority, the major amputation are performed 60%, and the minor is 40%. So the majority of the patients undergo major amputation. And then we found, and that's not maybe so surprising, but what we found that we thought was surprising was that when we looked at the patient who had a major amputation as the first amputation, we found that 91% of these patients had never been amputated before. So the majority of the patients come into the hospital and have a major amputation are the first time. So they're really sick, we must say. So if we conclude on this registered study, we could say that the main results is these patients, as you have heard, suffer from chronic diseases. We also found in this study that they're diagnosed too late. And we have also heard further on that they're living with pain, but they also live with pain prior to the amputation, as we found that just 29% of the patients had already received prescribed opium 3 years earlier, before the amputation. So there's a large group here who suffers from high pain. And they are not prepared for the amputation, since 91% is amputated on the first time. And also we have a social gradient problem here. We have to take that into account when we are counseling the patient. And if you want to read more, we have published a paper here where you can read more about the lower limb amputation cohort in Denmark. But that was the characteristic of the patient. And now we go to the nutrition and amputation. So what do we know about nutrition in relation to amputation? Well, most of the studies that, if you look for the big, larger cohort studies, the only data we find is BMI. And that's the only data that tells us something about their nutritional status. And here you can see its range is from 42 to 34. And that's due to many of the studies come from the US. Then there was an older study from Sweden, where they have investigated 64 patients with transtibial amputation, and they have given them nutritional supplements. And what they found was, first, when they screened them, we don't know how they screened, but they found that they concluded that 84% were malnourished, and they also concluded that that when you give nutritional supplement, the wound will heal faster. Another study, a more recent study from Asia, with a larger population here, with 478 patients with diabetic foot ulcer, were screened with using the minimal nutritional assessment. And they found that 70% of the patients were in risk of malnutrition, and 50% were malnourished on admission. So it seems like we have a problem with nutrition within this group of patients. And Gao also concluded that the higher the amputation level were, the higher the risk of being malnourished was. So that would maybe be a link there. So what are the challenges that we face and the patient face? Well, we have old age. The patient have a high age, and when we have talking about high age, just as we talked with the frail patient earlier, we have to think about anorexia and sarcopenia. Then we know the patient have chronic diseases, type 2 diabetes, atherosclerosis, and both of these diseases causes low-grade inflammation in the patient, and they have that already, even before they come to the hospital. So the low-grade inflammation are there, they're affected by it, and some of the patients, when they come into us, fulfill the SEERS criteria as that is the systemic inflammatory response syndrome. And all that lead to that the patient are in what we call a stress metabolism. So their metabolism is higher than a healthy person is. And we already know that, and you've probably also heard that from Professor Khaled, that leads to loss of muscle, it leads to reduced healing and infections, and then we operate on them. They undergo major surgery. So we have what we call surgical stress response upon all of the other things. And that leads to a local and a systemic response and insulin resistance. And insulin resistance means that the patient cannot use whatever nutrient they get. So this is a problem. And that leads that the patient we see in the orthopedic ward is characterized by catabolism is it called. And that means that the patient have a high need for nutrients. The body has a high need for nutrients, but is not able to take it up. So the nutrient uptake is reduced dramatically, but the need is very high. So what do we see when we look at the patient? Well, we see some barriers. We see that patients do not have a very high dietary intake, and that is due to very low appetite, which is related to the stress hormones, and also due to a low gastric flow due to both the stress hormone and the old age. So these patients do not eat enough, and they don't have the capacity to do it. And what does that leave us? It leaves us with increased complication, increased risk of reamputation, and of course, a very high mortality. So this is the reason why the high mortality is seen in this group, because the patients are suffering from severe illness. And I have presented this as it may be linear, but it's not. It goes both ways, because when you have the barriers, you have the old age and so on, and it all goes around, as you can say. So today, all as the same as Henrik Kiel probably have told about enhanced surgical, what do you call it, fast track, that nutritional therapy is a part of the modern treatment today. So, malnutrition. What is the definition of malnutrition? Well, here, just in few years ago, I think in 2018, there was a new definition of malnutrition. And you could see this as a different kind of malnutrition. The red one is the one we are looking at, and the red one over here is called disease-related malnutrition with inflammation. Today, we do not talk about malnutrition without talking about inflammation, because these two go hand in hand. And in here, under the first red, you could see acute disease or injury-related malnutrition. That will be, for example, it could be hip fracture, who has a disease, but it also is the the patient with lower extremity amputation, because they could also be chronic, and they're also chronic, so they should fit both of the boxes. So I wanted to see, because there was no data on the nutritional status among these patients, so we made a study. We wanted to follow the patient from they were admitted and to 10 days after the amputation. And we followed the patient, we screened them with MNA, and we followed the dietary intake during the days. And then to measure the inflammation, we measured some biomarkers. I will come back to them. And we made a power sample to see how many patients did we need to conclude anything, to say something with statistical certainty. And we needed 42 patients, and lucky for me, that was what I ended up with. So this result is based on 42 patients with major amputation, and we followed them through the 10 days before and 10 days after the amputation. And this is the result of the nutritional screening on admission. And what you can see is 55% of these patients were at risk of malnutrition, but actually 43% were already malnourished. I only had one patient who didn't have a nutritional risk. And also, we found that 55% actually called for, explained that they needed help to oral care or help to brush their teeth. When we looked at the 10 days, the whole period, we could see that the patient's protein need was only fulfilled in 62%. And that leaves us to that they have a protein intake at 0.9 gram per kilo, and the recommendation is 1.3, so there is room for improvement here. The energy intake was a little bit higher. And here we can see like a graph with every green dot is representing for each patient, and you can see the protein intake. And the red line is the 75% threshold where we like to be, and the bold line is the medium. And what is interesting here is that it doesn't improve. It's stable over time. So the thought of the patient will eat better the next day is a myth within these patients in this sample. They do not get better. It's the same for energy intake. It's a little bit higher, but it's the same. We also looked at the fluid intake, and we had a threshold of 2,000 milliliters per day, and they are not reaching that either. So they do not drink enough, and the total fluids is also included any intravenous fluid. So the inflammatory status. Well, this is quite a new area for me as a nurse, so we'll walk through it together. This is SUPA. I'm not going to pronounce all this very fancy up there, but it's called SUPA. It's a biomarker that was invented in Hvidovre, and we use it to figure out which patients are ill and who is not. It's a protein that we measure in the blood, so that's a very nice thing. It is a symbol of the activity in the immune system, and it's related to the chronic inflammation, the low-grade inflammation that we see, for example, in patients with diabetes. It is also a way to express the severity of the illness in the patient, and it's also associated with mortality. We measure it about from 0 to up to just about 15 and below and above. And what we do, we use it in the emergency room in Hvidovre Hospital, and we see, the thing is, how sick is your patient? Because sometimes we can't really see how sick the patient are. And if you have a low risk of low mortality, low readmission, and healthy individual, you have a SUPA of 0 to 3. If you have a moderate risk, you have an increased mortality risk, prolonged hospital stay, and you have increased risk of infections and so on. You will be around 6 and up. When you come above 9 to 12 and above, you have a high risk of increased mortality, a high risk of a significant increased mortality risk and severe illness. And what did we found about? What we measured these patients? Well, in the whole group, they had a super in average of 5.9. So they are in the modern risk. So they are severe illness. And then we looked at the patient with diabetes and the patient with atherosclerosis. And you see the patient with diabetes have a higher super, 6.4, and the atherosclerosis have 5.5. But either way, they are both in the moderate risk category. Then we measured also the CPR, which is, you probably all know this, and it's an indication for acute infection. And what we can see here, I don't know if this works, no, yeah. We have the day before, and this is the amputation day, and then the day after until 10 days. And what you can see here is there's a little peak here for the infections. It is higher than when it's on 10 days. And the same here, it goes down and a peak, and then it's settled. So it indicates that these patients do have an acute infections when they're both before and after the amputation. So they are severe ill, we know that. They have an acute infection. But what about the inflammation biomarkers? Well, these 5 inflammation biomarkers was the one we measured. And the 2 highest up is what we call pro-inflammation. And there's one anti-inflammation and some monocyte down there. And what do we see here? That was what I asked my colleagues. What do we see? We see absolutely nothing here. We see flat lines. What would we expect to see? And you have to remember this is primary results. We would expect a peak from all of these to indicate this is an amputation. That would be the way the immune system would work, because that is what we see in other patient groups. For example, patient who had a knee replacement, you will see a peak when the patient is operated, and then it will flow, go down steady. And what we see here is nothing. We see no response on the major amputation. So, and that is, what does that mean? Well, that will mean that especially if we look at the lowest one, CD14, that is, this is something you measure when the immune cell is activated. Then you are able to measure this in the blood. And this is totally flatline, there's a minimum activation of the immune cells. So this may indicate, even that we know that they are very ill, that the immune system is like set out. There is immune suppression here, and the immune system doesn't work like we want them to. And remember, they're severe ill, and they have acute infection. So, to conclude on these 2, well, the inflammation status is that these patients have severe illness due to the high super. They have acute infection, but they also have a very low immune response. This is not very good. But it may also explain the high mortality and the complication. They have a very poor nutritional status, the nutritional intake is low, and we don't see any improvement over the 10 days post-operative day. But what do the patient think about this? Well, we made a paper about this. It's a quality study, and I asked the patient about the nutritional status and what they thought about nutrition. And they didn't, first when I asked them, they didn't know what I was talking about. One said, I have lost my leg and you ask me about food? So, but this is the results we came to. We had 3 teams. The first one was that these patients, they are very clear is that they do not expect anyone else but themselves to be responsible for the nutritional intake at all. They are highly motivated to eat because they're eating to survive. They want advice on diet, but they do not expect it because it is their own responsibility. And the reason why they keep on saying this is that they do not experience that nutrition is a shared mission. The second theme is related to counseling, and these patients I promise to tell when I come out and present this, that don't come to me and present salad and organic food because they reject it. This is not the way. This healthy trend everyone is talking about is not complied with them. Because what they think is that nutritional guidance is quite hard to follow if they suddenly have to change their way, and that is not very easy. The last theme is about feeling overwhelmed, and I won't go into that because you have heard that already by 3 very good presentations. So, to sum it up, what we see here is that the patient's nutritional status is poor, and it needs to be enhanced to prevent protein catabolism. The patient's capacity to recover is low due to the chronic diseases and the acute infections they have. The patient asks for help. They ask for our help to fulfill their nutritional needs. And nutrition needs to be a part of the care. So you could say, well, if you have inflammation, it will affect your nutritional status. But on the other hand, a low nutritional status do also affect the function in the immune system. So it is not, these patients have so low capacity, they are not able to recover on their own. They need the help from the nurses and the treatment. So this is the last. I started with this one, and all I need to say here is that nutrition must be a shared mission. Thank you.
Thank you, Pia. I think there's time for one quick question, if anybody. Yes?
Can you recognize this?
Yes. Okay.
Yes.
We actually, I think it's in our award, we think it's very difficult to measure the nutrition during the day. We've got these papers that we fill out every day, which doesn't actually it's like a standard, and and it doesn't match the thing that is made in the kitchen, which is a huge problem for us, because then we might calculate at the end of the day, and then it doesn't give us the right answer anyway. No. So we think it's quite difficult. Is there any good answer to solve that problem for these patients? Because we think it's quite a huge... there is a huge problem, and it is a very important issue for these patients.
Well, dietary monitoring is a problem. And it's been a problem for many years, especially because it has gone to the point where you have to be very precise. And if you're not very precise, it doesn't matter. And that's not true. You should keep your the monitoring of the nutrient intake, keep it as simple as possible. Estimate, just about. Don't be precise. It doesn't matter. The patient is not better or worse if they get 5 gram protein more or less. So estimate, make it reasonable, make it easy for you in the care to make this happen. That is my, it's not so good answer, but keep it simple That's the most, I think, the best advice I could get.